Good afternoon, everyone. Afternoon. All right. Welcome to our afternoon session. We have a panel on community-based interventions and the impact of historical trauma. So I am with 3 psychologists, which is quite exciting for me. It's an all-psychology panel. So with me is Elizabeth, I want to say Mbata, right? My Zulu brain, or according to Prof. Buthelezi in the morning, I don't know if I'm Zulu anymore. So there's a bit of an existential crisis there. Ndugu, I was asked to ask you how to say Mbata in Kenyan. Mbata. Mbata. Elizabeth Mbada. Thanks, Ndugu. She's our colleague from Kenya. Then we have Brianna Woods Jaeger. Did I say that correctly? Jaeger, sorry. And then we have Gugu Kigaba. That one's easy, right? Gugu's from South Africa and Brianna from the United States. I think let's just jump into the first question. Can you give us a snapshot of what you do, just briefly in terms of the work, the projects, both clinically and in terms of research? Elizabeth, can we start with you?
Okay. Good afternoon. Like you were told, my name is Elizabeth Mbathamuli. I'm from Kenya. Trained in Kenya as a clinical psychologist, currently living and working in Nairobi. My training is in clinical psychology, and I've been working mainly with displaced persons, people who faced war, conflict in the Kenyan context. I have worked with refugees in Nairobi, what was called the urban refugee context. I've also worked in Kakuma refugee camp and Dadaab refugee camp. And then in the last 5 years, I crossed over to Ethiopia, and I was working in the IDP setting in Tigray, Amhara, and the refugee setting in Gambela. So I saw Dr. Ngide, so I do have some Ethiopian people that I can relate to. And that is the work I've done so far in the humanitarian sector. In Nairobi, I'm currently working with MSF in SGPV response, providing mental health care for survivors of gender-based violence in an area called Mathare Valley, which is the second biggest slum in Nairobi. Thank you.
Hi, everyone. Thanks so much for having me. I'm really honored to be here. My name is Dr. Brianna Woods Jaeger. I am an associate professor in the School of Public Health at Emory University in Atlanta, Georgia, in the States. And I'm a clinical psychologist by training, and so my work really focuses on both prevention and response to traumatic stress among youth and families, and particularly working with Black youth and families, doing participatory research, so really thinking about how we can build programs and policy together, centering lived experience to guide us and what we need to be doing. And so a lot of my work clinically focuses more on treatment and group-based interventions, and then research-wise looking more at community level, and so things like storytelling, engaging in youth empowerment interventions, and other ways that we can either prevent traumatic stress from happening at all, or prevent some of the long-term consequences. And I think we'll be talking a little bit about some of our different projects, so I'll just highlight that in general, I work on both working with youth to, again, develop programs and policies to really promote mental health as well as prevent violence, and then working with families, particularly right now working with Black pregnant women who have PTSD, to think about how we can engage with the healthcare system to connect them more with community-based resources, and then also advocate for those resources to be more appropriate, because we have a lot of barriers in the States in terms of providing actual support for families. So I'll stop there. Thank you.
Hi, good afternoon. thank you. That seems to work. Yes. Thank you. Good afternoon. I'm Gugu Gigaba. I'm a clinical psychologist. I'm based here in KZN, a Durbanite, also trained in Durban from the University of KwaZulu-Natal. The majority of my experience in this field is focused largely around developing or creating interventions that enable access to mental health care in our poorly resourced contexts. So typically that has involved developing or contextually adapting and translating or making the evidence-based interventions from different contexts to be accessible and to be applicable in our context. I think there's been sufficient reason and motivation around why we need to do that from the presentations that we've had, which is primarily that in our South African context and in Africa globally, generally, we have a skills shortage for mental health practitioners. And so a core factor has been, how do we make sure that our mental health reaches the people that it needs to reach? So I've been affiliated very much with the Center for Research in Health Systems in University of KwaZulu-Natal, as well as currently I'm a PhD candidate that is looking at understanding more the mechanisms of transfer of trauma, particularly in traumatized populations, so women that are experiencing intimate partner violence, and also have worked quite closely with the South African Medical Research Council, the Gender and Health Unit, where we've worked with women that have experienced rape, again, to try and make sure that there is some kind of psychological intervention to enable improved quality of life. Thanks.
Yeah, thanks for that. So let's jump into some of our themes. The first one being the influence of historical trauma on mental health in your communities. Just a broad question to all three of you is, how have historical traumas shaped the mental health landscape in the community you serve? Maybe Gugu, can you start us off, and then Elizabeth, and then Brianna?
Sure, I'll be happy to do so. So when I was being trained, I remember my clinical supervisor told me that if you're doing mental health work in South Africa, you must make the natural assumption that everyone has experienced trauma in one way or another. So when the gentleman, I forgot his name, the last presenter was showing us the statistics, it kind of confirmed that, particularly when he was highlighting the prevalence and the multiple trauma exposures in the South African context. We seem to be leading by a mile. So that kind of seems to, it substantiates the assumption that we're working with a highly traumatized society. So there are, of course, historical reasons why that is so. I think Dr. Buthelezi laid a great foundation for understanding some of the influences on the trauma that South Africans have experienced due to our conflictual past. But we're also having to straddle that with current traumas. So traumas that people are currently experiencing and they're living with. For instance, if we are reflecting on the pervasive nature of IPV, where if we're reflecting on the fact that in the South African context, about 43% of femicides, so murders of female, is due to intimate partner violence, then we are literally working with groups that have historical traumas that are still perpetuated also structurally, and the structural inequalities, even to access, also perpetuate that, whilst at the same time we have additional traumas that our populations are experiencing at any given time. So the impact then of historical traumas also kind of feed a lot into what then gets done when people present with challenges. So it has to do with issues around access. I think also when we work with our populations, we start to notice, at least we've started to notice, that there is just a normalization of suffering within our populations. Because again, of historically, if you've been denied, access to mental health, but also your experiences have not been validated, to kind of help you to understand that what's happening to you is a mental health problem, then we have communities that are very surprised when we provide interventions that raise awareness that what you're experiencing has a name and its trauma, and this is how it is actually related to some of the social ills that we're constantly observing.
Before we move on, you'll kill me later. I'm going to put you on the spot here. Just based on what you're saying, part of what we say when we're training students is that community or community psychology is psychology. But we're finding that sometimes it's treated, or community work is treated as an addendum to psychology. And I apologize, please indulge me in this question for those who aren't psychologists, but I'm sure it's relevant to all disciplines. How do you respond to that?
It's so fascinating because the word community itself, I think, has been very much linked to, I'm sure there's an image that goes into your head when they say community. It's usually that impoverished, it has a color, you know, it's brown, it looks like me. And that kind of situates this idea that it's, and I think it kind of perpetuates, you know, the limited access, because it's saying, well, there's a difference, the community is there, and it's a different psychology. Whereas the exposure that I've now had kind of shifts that, because all we're talking about when we're speaking about community psychology is a shift in perspective, where we're understanding that the mostly individual-focused theories that we get exposed to when we get trained in psychology are necessary but not enough when we have to work with communities. So we need to actually be innovative in terms of how do we reach a community psyche as opposed to an individual psyche. So it informs, the definition informs the practice, and they're not two separate things. I don't know if you can be a psychologist in South Africa and not wear the hats of a community psychologist, because in order to shift the needle, we need to adopt a more broad, scalable, large-reaching kind of lens. Yep.
Thanks for that. Elizabeth, can I come to you with the same question around the influence of historical trauma on the services you provide?
I think borrowing from the morning in terms of the historical traumas that have gone on, I'm looking at how we navigate the tension between acknowledging these traumas, remembering them, and moving forward. And as I was looking at this question, I remembered, yesterday we had somebody from Rwanda, the Gatumba incident, the massacre that happened in Gatumba for the Nyamulenge community that is living in DRC. And what came to mind is in Kenya, we were supporting refugees from this community, and between April to August, they would hold commemorations of this event every year, and they would call on the community they would have video shows to show what was happening and reminding people of that massacre and that the community was targeted and they need to keep protecting themselves. But it would always leave me in limbo because the people would be sort of re-traumatized because they were constantly being reminded of what happened. And talking to the young people who were not even there that time and asking them, what does this mean for you when you see this? And you see the bitterness and the anger that is rising in them, yet they were not there. And for me, it would leave a feeling like, how do we honor this? We are not refusing that these things happen, they are historical moments, but then how do we move on from there? And so looking at that, it's promoting these commemorations as historical moments, turning points, that we need even the young people to be educated of these experiences, to speak out for the injustices and remind the world of what has happened, but then also allowing people to find healing, to find new ways of defining themselves and moving on. And so have the events, but let them be whole and move from not just remembering, but also healing, and new meaning making. Involving the young people in these events would be important so that they also define them on what have they had and what do they want for the future. Community dialogues that are now shaping meaning born from those experiences. So I think that is one of the ways I would do that as part of bridging these two. Thank you.
So what I'm understanding, Elizabeth, you're talking about a situation where there are these events, people are quote unquote re-traumatized. In terms of the interventions that you tend to do in the community, do you go in holding this in mind, or is this something that sort of evolves in process?
It has evolved in process because it's something that it's within the community. They're the ones who are mainly bringing these activities, and then now for us to be able to see how do we get involved and also complete the healing circle so that it's not left as just a memory. And actually, you just reminded me of an activity that was happening in, if I have time, in Ethiopia. I worked there up to the beginning of this year. And in Tigray, you know, there was a lot of conflict and a lot of gender-based violence, sexual violence against women. But then the community remembered an activity that is called Ashenda, that honors women's rights, honors women's freedoms, and when you go, actually women dress up and they move around and it's their time to be honored. And so we, using that activity to remind the ladies, like, you went through a lot, you're hurting, the community has demeaned you, but these are opportunities that the community provides, structures that community provide to honor women, to give them a space to also speak up. So using such kind of community-based existing events to still bring hope and healing and dignity of the survivors.
We do hope that we're going to hear a little bit more of what goes on in terms of your humanitarian work as well. Brianna, can I jump to you with the same question?
Yeah, so I think some similar themes in terms of, obviously we have a different context in the US, but there's a lot of shared history around oppression and identities and not being connected to that. I think similar, really trying to balance this focus on both historical trauma, but also historical resilience and resistance. And there's been a lot of movement around recognizing the strength of the community, even when we talk about historical trauma. But then also thinking about how historical trauma is not always so historical. So structural racism in the US very much perpetuates historical and current day trauma. And so thinking about how do we bring that into our understanding and think about more of a community lens, how is this whole community being affected, and of course then families and individuals as well. So one of the things I think that's really helpful in the work that we do is storytelling. And so really having a process of engaging, especially with young people, because we heard a lot from them about almost the pressure of historical trauma, and that they carry this and they have higher expectations to do twice as well, and you know, all the different, and their parents preparing them for police violence, and you know, all of these things that can be really heavy. And so starting to hear that from them and thinking about how can we engage intergenerationally and healing and shared storytelling to both recognize definitely the history where we came from, again, both the trauma and the strength, and then also what we can do to reimagine things currently, so building from those strengths. And so a lot of this happens through, we do photo voice, we do theater performances, other ways of doing this shared storytelling intergenerationally, led by youth. So youth are the ones putting on often the performances, but then engaging in this dialogue about what does this mean. And what we found is that in that process, there's this sort of validation of the shared trauma. So that's really important. We need to name it. We need to validate that this happened and that it is and was a trauma or traumas. But then there's also this meaning making. And so really starting to understand, like, what does it all mean, including a lot of critical consciousness. So recognizing traumas that maybe have been intergenerational or transgenerational in your family actually have a structural root. So your family wasn't crazy bad, you know, somehow deficit-oriented types of frameworks for that, but thinking more about if I know more about the structure that actually frees me from some of the burdens I've carried or our families carried generationally. So doing that meaning-making process, and then really building those community bonds for action. So a big piece of our work is we definitely believe in clinical intervention is critical, right? The healing process individually, family-wise, community-wise. and we have to address the structural violence. And so thinking about how we engage in policy advocacy simultaneously while we're engaging in developing, adapting, and implementing these interventions that need to happen on, again, an individual, family, and community level. So it's complex work, but I think the more that we do the whole, the more folks can really not only have that historical trauma validated, named, and recognized, but also see the pathway to healing and imagining those futures. And we talk about radical hope, like really having that vision of where we can go, grounded in our history for sure, but also imagining the way forward. And youth, I will say, are great partners in this because they just sort of give that energy and innovation that helps really ground these intergenerational conversations.
Spoke about policy advocacy. So what are some of the policy level barriers to your violence prevention work?
Yeah, and I think I'll give an example because I think it shows how, again, what I was talking about, how the mental health interventions and the policy go hand in hand. So currently we're doing, I mentioned that a project where we're focusing on screening Black pregnant women for PTSD and then connecting them with community-based resources. And we do the screening and brief intervention in the hospital setting where there's a lot of historical trauma and medical mistrust, valid medical mistrust. And then we connect to strength-based community resources to try to build that bridge. In that process, because the community-based resources are often limited, we need to do policy advocacy to make sure that we can refer folks to appropriate and sustained intervention. And so, for example, right now in the US, I mean, there's all kinds of policy issues, barriers, but like SNAP, so that's our food assistance program. We've done research to show that SNAP, having more access to food security, actually reduces violence. It's actually associated with reductions in firearm mortality among Black youth ages 10 to 18. So that's a pretty big deal. Like that's an upstream intervention we can be doing to really prevent violence. So we've demonstrated that. And currently, I mean, they froze SNAP for several weeks, but now it's being more restricted than ever. And so that's a barrier to us actually meeting our goals around public safety and all of these things that people talk about. So being able to illuminate that and then work on the advocacy around that while we're simultaneously helping mothers navigate how do I get food security in this current environment. So that's a type of example of where we really see it fitting hand in hand, and we need to be doing both in order to really promote healing.
Staying with you, Brianna, you talk about interventions and some of the barriers there. Maybe switching gears a little bit in terms of cultural responsiveness. How do you ensure that communities or the people you service take ownership or feel like this is for us, by us, in the work that you do?
Yeah, so our work, we use a method called it's community-centered participatory research. So that means that anything that we're studying was identified by the community. So I don't come in as a researcher and say, hey, let's study this or let's intervene in this way. We do an extensive process, which often takes a long time, of learning what the community wants to both research and intervene on, what the capacity is, and then building the research agenda from there. So that means that from the very beginning, but the community, as we talked about earlier, can be defined in a variety of ways. So we have a community action board, for example, that we've had for over a decade, and that engages a variety of folks from the community, from healthcare providers, educators, folks with lived experience of trauma, parents, youth. We have a range of folks involved in decision making. So that's the key part, is that they're making decisions about the research we're doing. But of course, there's people missing from that table, right? And so even when we're doing this work, we have to always be thinking about how we're defining community. Are we being inclusive? How can we stretch and grow? And so we do a lot of community forums, community outreach, and so we're constantly, while we're doing the research, disseminating that research, guided by our CAB, by our Community Action Board, to have this kind of continuous exchange and growth and evolution. So it's very iterative, which a lot of people are uncomfortable with, because when you're doing like a randomized controlled trial, you're not thinking about being iterative. You want to have it pretty set. But for us, we found that it actually really makes sure, like you were saying, that there's ownership in the community, and we get it's such better research. We're not just coming up with an idea in our head, it's grounded in research. So we do a lot of qualitative research with the community and feed that back. So they're hearing the themes, oh, that's what my neighbors are saying, or that's what the providers that work with me are saying. Oh, let's interpret that together and then decide what we're gonna do. So they're very actively engaged as researchers, helping us have more relevant and sustainable research. So it takes a long time. Like I said, we've been doing one project for a decade and iteratively developing it, but it's sustainable. Like we know we have the capacity, this intervention will continue. We're not worried about at the end of funding it just going away because the community owns it. And they owned it from the beginning, like we're gonna study this. So you have to be committed for a long time. And you're not gonna do like one grant or one project to accomplish it, but I think that it really, I mean, the benefits are, for me as a researcher, I feel much more effective and impactful, even though it's also, you know, takes a lot longer. So I might not be moving as fast, but it's like we go further together. So I think that's been really important for our work.
Thanks for that. I'm so sorry, I'm still with you. The educator in me is emerging. I'm just aware that we have friends in the labs that are with us, we have students in the audience. So what do you mean by things like participatory action research and a community advisory board, so that we're just not talking amongst ourselves?
Yes, no, absolutely. So there's different ways people define these things. So I'll just share like some of our principles. So when I say participatory action research or community-centered research, for us what that means is we're really guided by a set of principles where we co-own the research process and products, meaning that we're doing, like I said, we're making decisions about how we're conducting the research together. We're making decisions about what we study together, and we're also making decisions about dissemination together. So we co-author publications, presentations, we make sure we're doing things like now we're getting more into videos because our young people are like, you gotta get the word out via TikTok and these other things which I totally don't know anything about, which is why partnership is so key. But that's what I mean by participatory, that they're really engaged throughout the entire research process, not just at the end, which I think is really important too, obviously, but when they've defined the research agenda, it just has there's that ownership again. So that's what I mean by participatory. It's very active, very participatory with everyone involved, including the academic partners. So we're all partnering together, and there's a lot of tensions we have to navigate with that because people have different agendas, different resources, et cetera. But that's what I mean about that. And then our community action board, so again, our principles are that we're transparent and we share decision making. Not everyone does that, because it takes a lot longer. We use consensus-based decision-making, but that means we might be on something for a really long time, right, until we reach a consensus. So that's one of the things we do. We also are always thinking about this balance between research and action. So while we're doing these like 5-year studies where it's gonna take a while for the data to get out, what are we doing directly in the community at the same time in terms of training, in terms of outreach, capacity building, and our CAB hold us accountable to that. Like they'll say, this study, we've been talking about that for the last 3 meetings, what are we doing in terms of training in the community? So that kind of accountability structure is what our CAB provides. And so when I say CAB, that's really our accountability structure to follow these principles. And the last thing, I mean, I already mentioned it, is just the co-learning piece. So as a researcher, obviously I come in with certain expertise and ideas and experience, and as a person, like I'm from many, like the community that we share a lot of identities, but then I have to be willing to learn and to put my agenda aside and have a way that we do that, right? So this co-learning, again, it's very iterative, but that's another key principle of the way we do that work.
Thank you. Let's go back to the culturally responsive interventions. So I'm looking at you, Gugu, I'm coming to you. Are there strategies that you've been using that are specifically culturally relevant, or can you speak to us about that?
I mean, I think I would add to what Brianna's been raising, because a lot of, in the participatory action research approach, you have to utilize strategies that then are culturally appropriate in order to enable buying will. So that long phase of building will, I think, is what Brianna was describing. And I wanted to just kind of double click on that, because it's such an important component to write even in our project planning phases when we're thinking about doing community interventions, especially for funding purposes, because there's always a frustration around, you know, are we meeting our intended objectives in the time that we intended? And usually when you're working in the community setting, that's not always up to you, right? Because the movement happens at the pace at which you are able to build will and get buy-in so that you can actually drive to the community that this intervention, and with the community, that this intervention is actually for them, and it use their words. So that's one thing. So in our engagements, the discussions are broad in terms of the stakeholders that are involved at the table. I mean, as you were speaking, I had very vivid memories of us having to go to a chief in the south coast of KZN, and we had to bring a sheep. And because we needed to gain access to their space, and it was a multinational collaborative. And I remember one of our stakeholders at the time was like, well, we're actually not allowed to, slaughter animals, right? So how do we now reconcile, this idea that you need to bring, a live sheep for a chief? And I represented the Zulu voice there that says, you can't go to a chief with a slaughtered sheep. Because now you're going to burn your bridges before you begin. And it seems like such a small detail, but you can't arrive, and they kind of overrode the feedback that says, I cannot be the Zulu girl in the room that arrives with a packet of slaughtered sheep, right? It needs to be alive. It needs to be walking. It needs to be ceremonial, and all of those things are necessary to gain access. And it was such a fascinating experience when we did arrive at the chief's space, and he had all his advisors, and I was overridden because I was a junior member of the team at that time. And then I had to become the translator now of the chief's disapproval of these packets of meat that we had brought whilst we were trying to gain access, right? So for it to be culturally relevant means you need to understand the culture in which you are intervening. You need to understand the different customs in which they operate, which can sometimes clash, right? Because they were saying, well, our funder is not going to be able to reconcile the idea that you guys bought an animal. It's not on your budget, right? Generally, when we draw up a project budget, we don't list an animal. But now, this needed to happen in order for us to gain access. So the translation then was of the chief's disapproval of this process, and which could have been missed if you don't have the language, because I'll again also relate to the fact that I'm a Zulu person. Dr. Mtele is creating a nightmare, then he left. Ne? So if you don't have the language, you can miss the nuances of the disapproval, because Zulu people can be very humble. And so he was speaking his disapproval, but with a smile, right? And we had brought in a basket for the chief's wife with bubble bath. This is rural KZN. Bubble bath, and little bath salts. And you could see the chuckle, the chuckle amongst the chief's advisors, where the chief was saying, oh, this looks really, really like, I think I've seen this on TV. I feel like I've seen this on TV. And that was his way of saying, you've missed the mark. You've completely missed the mark. And what happened as a result is our next meeting with him was 3 months' time. So you just moved down the ladder in terms of priority, because you failed to understand things that represent a key core value of a community. So if you can't demonstrate as a researcher that you're going to be able to respect the values held by the people, they can't trust you to help them. Particularly for something as sensitive, again, as mental health, where the initial point that I made was a lot of the time in our community, there isn't the awareness that there's anything wrong with us. This is suffering we've always known. So you actually coming in to say, but it shouldn't be this way. And so in order to gain trust, you need to utilize the language of the people. So the language is important, even if you're not fluent, especially because we collaborate, in different countries. We need to trust our team members that are part of the culture so that we give them voice in spite of the seniority. The second other component, which you also touched on, is the utilization of storytelling. And today I've been so fascinated. There was a presenter who spoke about the case of Musa. There was a presenter who talked about that's how we take messages across. We like stories. So we create stories that enable self-identification. And it was that interesting conversation with Vuyokazi was saying, sometimes, you ask these questions, any other traumas, But I don't know I have trauma, so I'm going to answer that question. I'm going to say no, because I don't know what you're talking about when you're saying any other traumas. If I create a story character, so in Zulu inganekwane, it's a story, it's a fairy tale of sorts, but it's a character that is immersed in this world that you're in, that presents with these symptoms. We know these symptoms. The community that we're going into don't necessarily think they are symptoms. So we create a character that embodies depression, that embodies trauma, that embodies anxiety, and we call him or her Nontobeko. So I'm talking about Nontobeko. And as I speak about Nontobeko, the person in the room who's experiencing this is like, I'm Nontobeko. So now they can self-identify. But now if we're working again within a cultural or a community lens, so I'm using the South African story as an example because our health system lays the community as the first entry level for care, right? It's community as in house to house, but also PHC as a direct link. That means that if I'm going to teach the people in the community about Nontobeko, someone in the clinic has to know who Nontobeko is. So that when a patient comes and says, I'm Nontobeko, there's a clinician there who's like, I know what Nontobeko is, that's depression, and this is what we do next. So it's working with the different stakeholders at the different levels that participate. It's then also acknowledging that in our African context, a lot of the time, we are very open to describing our distress in physical terms, right? So I have a headache. Or I had dreams, right? For my dreams, I'm not going to Lunga, the psychologist. I'm going to the traditional healer because my ancestors must be saying something to me. And it's the traditional healer that's going to interpret the dreams and tell me what's happening. That means we cannot leave out the traditional healers in our work in community interventions. So we have to work with traditional health practitioners. If there's a sadness, it's the words that we use again, like my heart is sore, I'm going to the faith-based healers. I'm going to go to church, they must pray for me, right? That means we can't leave the faith-based healers as well. So the layer of people that you engage with when you're doing community interventions is broad. Hence, again, the building will story. And then it also speaks to then what are the culturally appropriate mechanisms that you use. You have to have a great sense of the community that you're working with so you can know the primary places where they go for help. It's not always the health system. They primarily don't go to the health system first. So how do we reach the places where they go first so that there can be a partnership and an understanding that we're not competing for patients. It's 0.2 psychologists to 100,000, if I heard correctly. We're not competing. These are all our people. So it's kind of engendering that and finding ways where we meet each other so that we can help the patients.
So you're talking about relevance, you're talking about applicability. But sticking with indigeneity and its importance, Elizabeth, I want to come to you. I'm wondering if you've encountered any resistance in terms of integrating sort of indigenous knowledge systems in what you do?
I would say yes, especially looking, we call ourselves partners in trauma healing. So indigenous practices of healing that might not be necessarily captured in our clinical interventions. And one of them is spirituality. Something that maybe in our Western-based approaches is not something that may not be highlighted as part of it, but when we work with the groups I have worked with, spirituality is a pillar in meaning making, in healing processes. And so you find a lot of times like when we do our groups, we have these rituals that we encourage people to do. And the interventions would be like try and get options that are non-religious, but your participants want to use religious interventions and rituals that make meaning to them. So trying to merge this so that you're able to bring this importance, that spirituality is important to them, and how that can be used as a healing. Again, going to Ethiopia, they talk a lot about holy water. as something that is important to them, that helps in healing of trauma. Scientifically, maybe not yet, I don't know if there's research on that, but it's important to them to allow that, for them that is something that brings healing and completion. And so incorporating those kind of practices is one of them. So spirituality, the issues of praying, believing that there is something else. It's not delving into fatalism that God has it all, but allowing them to express that part of them as part of their healing journey, and knowing that there's something else that gives them hope. So the other one for me would be a lot of the interventions we have been using in the community are written in English. So when you go through, in psychology, we talk a lot about cognitive behavior therapy, which has a lot of assignments and writing activities. Many of the people I work with in the rural areas have a challenge of literacy. So when I'm writing things and explaining things, they may not make sense to them. So converting those into narratives, where we use picture books that are contextualized. An African woman, carrying firewood, an African woman doing something, and using those things that they can relate, like she said, so that you can draw narratives out of that. So using visuals, using narratives, more than Western-based tasks and assignments, converting those, so trying to interpret the interventions into a more contextual activity. Use of movement, touch, finding things in our body, so somatic-based interventions that speak to what we are feeling in our bodies, and attaching that to trauma and how it presents itself, or attaching that to regulation. When you move like this, what does that make you feel like? Is that something you can be able to do that? We've also done a lot of working with cultural liaisons, or people in the community that before we do interventions, that go through our interventions and translate them into relatable things for the community. So you want to do this intervention, how does the community look at it? I remember one intervention that I'm going to talk about it, about food. The role of food and refreshment in healing. As Africans, we are happy when we are eating, isn't it? It brings us together. But then sometimes interventions are like, is it necessary? It's a cost. The financiers will say, what does it do? You are the specialist. But when you bring food, when you bring refreshments, it brings people together, And trying to bring these cultural activities that bring people and say, let's use what you have, let's merge it with what we are doing and let it make sense. So these cultural people look at the practices and interpret them in a way that will make sense. So in this intervention, somebody had said, okay, you can give them juice and biscuits. And then in this community, it's very patriarchal, and they say, you cannot give an elder biscuits. What is that? And it's these big biscuits in small packets. The 5 says, this is an insult, this is an elder, this is a man, so this cannot be. So we had to sit with them and say, okay, how do we do this? What is important? What does it make sense for this man? So those kind of things, working with the cultural people to be able to say the language, the terms that you're using, what do they mean for these people? So using cultural liaisons, people who interpret our manuals into the culture, using visuals more than literally work and narratives, and using spirituality as is applied. But then also on this, we also are careful to be able to point out harmful practices. I have worked in places a lot where there is gender-based violence, where IPV is normal, where things have been normalized. Domestic violence is normalized. And you see the clash even with when you're working with the local staff, how this is a struggle for them. And also trying to highlight, what does it mean for you when your sister is being beaten? So trying to build focus group discussions about the harm? Are you seeing another side of this instead of just imposing, don't do this, don't do that? So a lot of dialogue, a lot of contextualization as we do these kind of things. Thank you. Sorry, I've taken too long.
Very good. It's nice to see some of the parallels between what you were saying, Gugu, and what you're now saying, Elizabeth. We've come a long way since Freud. So going to this idea that you've had, Elizabeth, around speaking the language and using particular strategies, it sounds like it's also in aid of building trust and rapport within the communities. Could you say a little bit more about that?
Yeah, so I think we talked a lot about community participation. That begins right before the intervention, what you're going to do versus the needs of the people that you're going to work with. So building trust starts with engaging the communities right at needs assessment. We are a mental health organization. We are specialists in mental health care. But what are your mental health needs? How do they look like? And then building our assessments around that so that we engage them, they know this is what we are planning to do. We, again, coming back to participation through leadership, engaging the leaders of the community, identifying the leaders so that we are able to inform them, this is what we are planning to do, this is how it looks like, how does it look like for you? Continuous community education on the impact of mental health and the benefits. So one of the biggest things in this area for us has been testimonies. That once we do interventions, the people who have benefited from them, use them as ambassadors, let them go out there and tell the others, it has worked for me. Yeah, a lot of times when we go there, especially as NGOs, there's the expectation of material support, that if you give me a clothing or medication, it's not bad, but that is what is going to help. So using word of mouth that actually I got help, and we started getting feedback, people saying, actually, what we are getting from you is better than the material because it's long lasting. But I came because I saw my neighbor changing. I saw my husband changing from who they are. So that kind of engaging the community, continuous education on that, and using of testimonials. Within our setting with the clients is always explaining to them and engaging them in decision making. I'm here as a professional. You're presenting with symptoms that we call them trauma. What is it you're looking for? How can we achieve what you're looking for? So setting goals, basically what we call trauma-informed care, that is sensitive and engaging the patient, the group, so that you move together. There are times we've had sessions that we've planned, we are going to talk a particular thing, but they come and they say, we had that, like a lot when I work with South Sudanese, they'd say, we had news that back home people have been attacked. And then you want to say, okay, but today we're going to talk about this. So you shelve that and say, let's embrace what you're talking about. It is what is important today. Let's talk about it. So they see this is a partnership. It's not always about my agenda and what I'm going to do. It's about also what you want us to do today. So merging those two together. Thank you.
I think the question that pops into my head, Brianna, it might sound problematic, is it measurable, right? So how do we measure the impact while we trying to build trust?
Yeah, and I don't know if I'm the best one to answer this because I'll say, I think I'm a big process person, so I do think our process metrics, we can use those, but I really believe in qualitative research and being able to, we're talking about storytelling, tell the story of that journey too, because a lot of times people throw around, trust and these ideas, and it's like the journey of trust is different than I have trust. And so a lot of what we do is our history as a partnership. We are really honest about that. So where have we had ruptures? Where have we had to repair? Where have I had to take accountability for either myself or the system that I'm in doing harm to the community? So a lot of it is really documenting that and then sharing it very openly, so that transparency. So when we go out to a community forum, it's not all like, we've been perfect and we're, it's here's what we have done, but here's the challenges we faced and how we've navigated them. And then I think to the point of having, peer providers, in our case, youth leaders, be able to be the voice of that. They can say it much better than I can, and it's also more authentic. They're talking about, when I first came, I felt like a token, right? I felt like, oh, I'm going to be the youth on this board. They're going to just, use me for this. And here's how we navigated this. So a lot of it, I would say, is more like storytelling or qualitative. There are certain measures that people are trying to develop to like measure the authenticity of partnerships. And I think those can be used. I think sometimes they reduce it to certain items that, but they're still helpful to give us some sense of it. But I think some of it's also like common sense. Like we know what kind of leads to trust for us, like when people show up authentically, when they show up when it's not convenient, when they're consistent. Those types of things, I think, are real measures of trust that we can just know. And again, working with young people, they'll call you on your stuff right away. So that is really helpful. But I think even other communities, once people are calling you on your stuff, you know that you have built trust. So that's like another, the fact that you challenge me and criticize me means that we now have trust. I take it as a sign of respect when people do that. And so modeling that kind of relationship building, I think, is a part of it. But measuring it, it's a good question, because I think people often say it and think it's easy, or once you don't have it, you just kind of move on, but that's not the journey of trust, at least not in the work that we've done.
Gugu, I'm going to come to you for a brief comment on building trust, and then maybe ways in which, I don't know why this word measuring is coming up so much, and ways in which you've assessed whether interventions are effective.
Yeah, but I think the word measuring is an important one, because I think I think measuring mental health service provision generally, in our context in any case, has been a problem because of the types of mental health indicators that are captured and reported on, which then inform the type of resources that are allocated to providing mental health services. And the underreporting in terms of the actual data collected, even within our health systems, they actually contribute to the continued low, mental health stuff, in my humble opinion, right? That if we, it's kind of like how the 2Ks, the young children would say, if it's not on Instagram, it didn't happen.
You might have to contextualize, right? What 2K is.
so it's the younger generation, so children that are born in the 2000s, and they like to say, if it's not on the gram, it didn't happen. It's kind of talking around, if you don't document it, it's like it didn't happen. And a lot of the mental health services then don't get documented because we don't have proper indicators in place to track, which then gives a measure of how long it takes, what are the resources required, and what is a realistic and feasible mental health indication in the South African health system, from community all the way to tertiary. So that's the one thing. So measures are really important. What we haven't done well also is identify process measures, which is what you are now speaking about, and Brianna is also highlighting, that what is the cost of putting in place sustainable mental health interventions. So timing and measuring the time it takes in order to build will, and even the time it takes for structures that are created to provide mental health supports in the community, if we don't have, tools for them to capture the work that they've done, which is more process work. It's kind of like, do we create a formal indicator for number of mental health talks done in the community and see that as a valid measure of mental health service provision? Because we can't only focus on number of patients initiated on psychotropic medication as an indicator. It's not a sufficient measure. So I think maybe, the word measurement is an important one in order to unpack this thing of, what are some of the barriers actually that prohibit sustainability of even some of these innovations that we find in our labs, and make it difficult for them to be taken up and sustained, right? But you were asking me also around the strategies for building and maintaining trust. I think I'd double click on what Elizabeth was saying, that it's important to define your scope. It might seem quite pedestrian. It's important to define your scope of practice so that everyone else's scope is respected. It's important to declare the limitations based on your funding so that you don't overpromise and underdeliver. And it's also important to, again, exercise, the rules of partnership, true partnership, where you say, you know what, the CDC has cut our funding. So the facilities that we thought we were going to reach, we're not going to be able to do it. So how can we then participate such that the facilities that are going to continue receiving the funding maybe become the base, but invite your friends. So as opposed to doing an intervention within a particular district, for instance, you do an intervention for a region, but only utilizing those facilities that have been funded. So you become innovative through engaging with your stakeholders and do that which you said you were coming to do, and if there's a change, to communicate it, because that builds trust. Yeah.
Okay, very quickly here, colleagues. I want to talk about the ethics of what we do. So ethical complexities of working with vulnerable populations. So this is a broad question for everyone. How do you navigate the ethical complexities of working in vulnerable communities, especially when balancing clinical goals, touching on what Gugu just said, with community needs, right? I'm now looking at you, Brianna. Can we start with you?
Yeah, I think it's definitely a challenge. I would say kind of a theme that we're saying is really being upfront and honest about what those are. So as soon as you see an ethical dilemma or challenge, naming it, and then again, our CAB is where we talk a lot about this, but having a process, if you have a CAB or if you have some other way of engaging stakeholders, and how are we going to navigate it. So one of the things we often face is the urgency of the issues, right? So in terms of violence prevention, for example, we have these extremely disproportionate rates among Black youth when it comes to community violence. And there's a strong urgency in we need to solve this crisis. We need to do something now. And so the question around, but if we don't have evidence of what's effective, do we just try things? And how do we try things is something that we have to navigate. And so the idea around that is really tapping into the wisdom and the lived experience around the room, because sometimes there are tons of ideas or tons of things that are actually working that just haven't been scaled, they haven't been researched by a CDC or someone, but they are effective. And so really, first of all, being able to have a deep conversation about it, and as a researcher, acknowledge our limitations, and then recognize there can be a lot in the practice world that we have not learned yet and that we can learn together. So that's one thing. But the other thing is, really creating space for people to work through some of that. So I think our community forums are good because they're intergenerational, and we have such a variety of folks at the table. Because sometimes there's also, with working a lot with youth partners, there's this, and I have it too, this desire to protect them. And so we don't want them going out and doing certain things, especially with policy advocacy, where they're going to get the brunt, right? Or they're going to be they're vulnerable. And so listening to our youth partners say they want it, they're eager for it, they're leaders, they want to be seen on the gram, on TikTok, on the news, even though I know what the media might do with that, we have to talk about that openly. So there's an ethical dilemma there in terms of the adults in the room and our experience and our awareness of what might happen and how we want to protect those that are minors. But then their the youth lived experience and leadership and wanting them to have that agency. And so we have that conversation. And we don't always get it right. And so that's, again, where that repair has to come in. I think because we're doing this such a long term, it helps, but that's definitely something that's a challenge for us. And then I'll just say for the clinical ethical issues, I think we all probably, we've acknowledged that CBT, some of our interventions, while effective in certain populations for certain things, have limitations. And when that's, quote unquote, the gold standard or the best thing we have, how do we work with the limitations of that? For me, a lot of the limitations have to do with, I worked in juvenile justice settings where youth would get CBT and these interventions that actually were extremely helpful for them in that setting. it's not a setting we want them to be in, right? And so then when they go back out into the community, it actually made them vulnerable, some of the things that we did, because that was not the way that the community related or communicated, and we hadn't prepared them for that, and we hadn't prepared the community. So to me, that's an ethical issue I need to be thinking of as a psychologist. Yes, this intervention is strong, has evidence base, and can do these things for symptoms, but what is it gonna do for this young person's life and their safety? And so really being able to think through that, again, I'm fortunate to have a board, because these are things that we aren't gonna solve one person just thinking through it. It has to be a dialogue, and we need to document it. Like what we did, why, what were the outcomes, what can we learn from that?
Very briefly, Gugu.
No, I think Brianna has touched on them, it's always such a touchy space. As you were speaking around, some of the ethical complexities with vulnerable populations, I struggle with the respect for agency, which in itself is a strange thing to work with when you consider, there's a big question around but how agentic can a vulnerable person actually be? But at the same time, you don't want to perpetuate disempowerment by asserting that your clinical, assessment and recommendation trumps what they need. So there was like the interesting preliminary findings of the current study that we're working out with the SAMRC, where we're trying to understand all the different mechanisms around, intimate partner violence, and trying to understand how come women will go and get a protection order but withdraw it. And in this brief, focus group or like individual interviews actually around, so can we understand a little bit about how come you did the protection order, and then their request is not for the person to be arrested. So the desire is not for my partner to be arrested. They want the police to talk to them. So I'm giving the protection order so that they can see this is significant, and now I've got the police involved, but I want to actually activate this cultural tool of an elder talking to or someone with authority speaking to, because if the policeman speaks to you, then you'll stop it. Which is just, it's such a culturally nuanced response. Like, we don't want them to be arrested. We want you to talk to them. And I thought that was really powerful. But it just kind of leaves us stumped as clinicians who are like, but this won't end well. The statistics are telling us the likelihood of prolonged exposure to this violence is that it won't end well. But I have limited capacity at that moment to affect you need to leave, right? So there's just so many different, experiences of that nature that touch on my, the ethical or moral story, yeah.
Anything to add, Elizabeth?
I think I would speak to this in terms of looking at the therapeutic relationship, because it's part of the healing and presenting the limits that you have this relationship that is positively impacting somebody, but there are ethical practices that might interfere with that and the trust that is built, and really just having this sense of relationship with your clients that can be able to explain to them the limitation of what your relationship is, that this is not a friendship, it is a professional relationship that is healing. It is based on trust, but there are limits as to what I can be able to do, I can be able to receive, and clearly explaining to them the consequences of crossing some barriers. So for me, it's just being honest and saying, this is our relationship, this is the benefit, and some of these things may interfere with that, and what are the options we have so that we sustain this beneficial relationship while keeping the ethical practices. Especially looking in, one of the things that I find a lot even with the people I supervise, the issue of giftings. It's an African thing to give gifts when you're happy, when you're helped. And how do you handle that with a client who is very appreciative that you've helped them move from point A to point B, and here they are coming to appreciate that? How do you navigate that so that you don't break that relationship, but you also keep the boundaries? So having a discussion on the consequences of that and other options of expressing the same gratitude. So that for me has helped a lot. Yeah.
Thank you, colleagues. I think I want to shift gears a little bit and bring the conversation to the audience. I think let's use about 20 minutes, and colleagues, I will be timing you. I mean business. So please bear with me if I interject or cut you off. It's just so that we keep time. And maybe let's, in keeping with Psychology Free, associate. Are there any thoughts that come up from the audience? I think we have a hand there, Michelle.
Hi, thank you very much. So first is a comment and then two things that I would like clarity on. The first thing is I love the fact that I think this ties well with the issue of identity, the storytelling, because it then gives us a perspective of what am I inside. We then think of social psychology, always saying groupthink is always the key thing. If you are in the outer, then you're out. If you're with us, then we protect you. So it also speaks to the resilience. I love that aspect. And then I wanted to ask again, in light with the keynote speak today, that there's a lot of change in the political and the policy arena where we're then talking about a lot of corruption, a lot of power dynamics that have changed from the traditional that was really protective and, yes, paternalistic, but mainly it was very protective, to the new crop where we're then talking about let's grab resources for the few that are then in power. So I was then thinking about donor funding, because we're then looking for a lot of resources from donations and the donor syndromes that we then end up having. So I'm thinking of it in a dynamic of one, how do we then make sure that the ethical issues that we're then trying to protect against are really championed, because there are individualistic, greedy sentiments behind, like the sheep thing that you were talking about. And then the second issue, how then do we ensure that the community that we then live in, because we are not going to be with them for all the time, we needed to be continuing after we're gone. How do we ensure that there's then sustainability without too much dependence on donor funding?
Yes, thank you. Thank you so much for the reflection. And the issue of donor funding is a touchy one, right? Because in a perfect world, you write the proposal as the subject expert and the donors give you the money to do the work, right? But I think it's quite tricky in terms of we can't omit the context when we write our proposals. Because that's the role, I think that's the benefits of having, people that are immersed in that context. So we need to be able to translate the ideas that we have to running the projects that help to meet both objectives of the donors and what we're trying to achieve in our context. My mentor at that time used to call it wordsminting, right? So we have to, as researchers, be very eloquent and diplomatic sometimes in how we write and represent it's kind of like an advocacy. So our proposals are actually advocacy pieces for the communities that we're trying to support. I hope that this makes sense. I can't remember the second part of your question. Sustainability, perfect. I think that a lot of the interventions that at least I've been part of, and I think both Brianna and Elizabeth, capacity building in the community layer, such that we don't want to leave, we don't want the project to end without the necessary capacity building and creating structures in place for support so that there's sustainability. So we've always, from the beginning, worked with the community, so whatever skills we have. So the lens we've used always has been, we don't come in with the experts, we have to train people in that community. And those people in that community, we support them in cascading the training and support down so that when the project stops, things don't stop with us.
I think if I can just add on to that, from a mental health MHPSS perspective, for those who are familiar with the MHPSS pyramid, it's really moving interventions to the lower levels of the pyramid where the community takes ownership of interventions. That it's not always the specialists with the academic qualifications and the high skills. What are some of the interventions that we can contextualize to be done at the community level? What skills can we give the community leaders, the youth leaders, the groups, the women groups, so that they can be able to learn to take care of their own mental health, and so that a lot of the issues are resolved at community level and less up there, so that it remains with the people, they own the intervention. If it's an area prone to domestic violence, how do the community speak it? What structures can they put in place so that more and more ownership of this intervention is not seen as a professional, but also healing from within the community?
And I would just add around the sustainability, I mean, exactly what you're saying in terms of integrating it into the community and thinking about that structurally too. So like, when this project is done, how will this be sustained in terms of a system it can exist in? And that can be an informal system. So moms groups are a huge thing in terms of some of our evidence-based practices can be continued through that. Even Facebook groups, which I was very nervous about, but if that is handled in a certain way and you plan for it and you build, it's like there's different ways we can get creative about building in that sustainability. But then also to the point about knowing our scope, it's like being really honest about what the limits might be and how are we going to navigate that? Because it definitely is always a challenge. Even when we write sustainability sections in our projects, it's like stuff happens, right? Policy changes, like there's all sorts of things that we can't anticipate. And so there's always going to be that challenge.
Yep. This is for Google and maybe Miss Elizabeth. The point on cultural sensitivity for interventions is a very crucial one. And I work with young people. And in Uganda, where I come from, elders are the cultural gatekeepers. And I think it applies to most African countries. And we know that some of the cultural expectations, cultural practices can be very restrictive and even harmful to young people. So I wonder how can these interventions, community interventions, one, respect the role that elders have, but also be responsive to the mental health needs of young people. Yep.
Thank you. So it's a challenging one, but it's almost like, how do we leverage the value in order to inform practice? A lot of the time, the cultural gatekeeping, you want to understand what is it in aid of, right? So if we can leverage what it's in aid of, so for instance, if we, I'm gonna make an example because this is the only thing that comes to my head right now, but it's around, you know, the monitoring of women's bodies, for instance, which is usually just there are cultural messages around that. You know, a woman must cross their legs when sitting, and a whole lot of messages that can be harmful because it can then vilify and alienate women from their own sexuality, which can also have various impacts, right? And if you go through a process of investigating what it is that makes this woman so adamant in, you know, monitoring women's sexuality, it's usually around fears around safety. So there's an awareness of the environment that might be harmful, and what they're wanting to do is to keep their young children safe and out of harm's way. So part of the participatory research is around trying to sit with communities at the different generation level to try and understand what's the value, what's the principle, so that you create interventions that don't seem like the mental health interventions are here to alienate the young people from the old people. We're not here to create a rebellion within the family, but we want to make sure that people are orientated towards a principle. And so if the principle is safety, then how do we package it? So it's in those preliminary discussions around how do you hear your daughter when she says this, and how do you hear your mom when she says this? Here is the principle. So what can we do in order to reach safety? Because what we ultimately want is for you to be protected, right? So we can use that same kind of idea around mental health problems, right? So how do we reach the principle to inform the intervention so that we actually move people towards each other as opposed to creating segregation around the generations? I think, again, the story approach has been powerful in doing that, because once you've reached the principle, then you can create a story that unites so that it informs a change even in the language that we use, right? So that the language we use becomes reinforcing of what we're trying to achieve. I hope this answers partially what you're asking. Yeah.
I think this would be an ongoing conversation, maybe over time, but I'm looking at it in terms of acknowledging that the world is changing and the structures that were there before are also changing. Before, I grew up in a world where young people and children were seen. It's the adults who made the decisions, but now we are seeing young people rising up and wanting space to be made for them and acknowledging that that is a shift in how structures are. So one way, an immediate way, is maybe creating youth-friendly spaces where we allow them to express themselves, we allow them to discover themselves and have these honest conversations about life, about their dilemmas, about their expectations, and then finding ways of having these meets with the adults and having discussions in that safety, that now this is not a young person being disrespectful to an elder, this is a young person finding meaning and space and creating that space where these conversations can be had and see how they shift things so that you are taking the needs of both, that this is a safe space, just the way we say in therapy, this is a safe space, you can say anything, you'll not be judged. So also creating these youth-friendly spaces for the young people and these safe meetings where they can be able to talk to the adults or the elders and express themselves and get listened and find common ways of working or adapt systems. So I would say maybe that is where we have begun. I am in a project where we have a youth-friendly center, and we try to keep it a safe place for them, but we do bring in adults so that they can have necessary conversations, and we feel it is having an impact. It isn't measured, but there is something happening. Maybe in the long run, it could lead to something better.
Thank you so much. And Lunga, 1 minute, please. I think you are very right, but I think also everyone in this room might need to address our own biases, because sometimes the resistance comes from us, where it's culture and this is how it's supposed to be. And when you're met with a young person, the resistance that you have stops you from giving them the help they need. So, yeah.
Thanks, Claire. I think we have space for one or two more. Carlo?
All right. I agree. We will listen and not judge. Should be should be the hashtag. So, in the spirit of language, I just want to stand up. Thank you, Siyabonga, Ngiyabonga, for everything that you have spoken, and thank you for bringing this, your experience, your expertise, transnationally. Like, US, South Africa, East Africa, and there's just so much that is in common. My question to you, as experienced clinicians and researchers in the field, for us early career folks, I think that one of the reasons you are doing such important and effective work is because you are working with communities where you're from. And so these are your people. As for those of us who are just starting this work, how do you care for yourself when there's so much there are so many barriers that you have mentioned? There's limited funding. There's so many systemic things that can be very frustrating to see and almost sometimes feel helpless because you're also seeing what's on the ground. How have you managed that? How do you take care of yourselves while still doing the important work you're doing?
Yeah, I mean, that is such a great question. Thank you for bringing that up, too. It's such an important issue, and I don't, culturally it may be different, but I know, like in the States, we have the strong black woman schema, this idea that we have to be strong and resilient for our communities. Like, that is my way of showing my contribution. And so for me, it's been a journey to really admit when I need help and how I'm feeling and be vulnerable with my community partners. So I think, to your point, the benefit of doing this work with folks we identify with is there is that like shared bond around holding each other up. And I think there's also a lot of shared pain, though. So being able to have spaces where we've had meetings where that's all we talk about. So like the research agenda, what just happened policy-wise, for example, and how that's gonna disregard the work we've done for 7 years, that's painful. What just happened with a shooting in the community and this young person that we couldn't save, that's painful. So how do we make sure we have space for that? And that's why I think actually participatory research is therapeutic, because we're engaging in that authentic lived experience throughout the whole thing. But I will say for me, I've had to really lean on, having a community action board that I can be really vulnerable with and say when I think of leaving my job, like I don't think I can do this anymore, and have an honest conversation about that. Or when I lost my husband, I had to be able to tell them what was going on with me so they knew why it was hard for me to show up in the way that I had before. So being honest and authentic and having space for that is important, and I think is often not encouraged in some of our academic environments, and so we have to create that space, at least in my academic environment.
Yes, thank you so much. That was such a kind question, because it's very difficult work. Sometimes it feels like you move 1 step forward and 10 steps back quite frequently. I couldn't agree more in terms of the team that you have. That really, really helps when you have a good team where you can debrief, because that's really important. It's kind of like having an entire community as your therapy client. You're working with a big group of people, but you remember every face. And you're right when you say it's quite therapeutic, because it's kind of leveraging those moments where you came in to validate a screening tool and you discovered a person that had active suicidality and they got admitted in the hospital immediately. And you just see the impact of the work. It's also being really positively reinforced by a long journey of your practice informing a change in actual practice, which is unlike any other. I enjoy one-on-one therapy, but the idea that a tool that we developed, we validated and tested, is now adopted by a health system and is utilized, it's like no other kind of feeling. And then the occasional glass of wine, to be honest, so that we don't lose our mind, and phone calls to friends, and just having a really good support system to say, you know what, it's a lot that's going on. Yeah.
Thank you for that question. I think I would say one thing is continuous self-awareness, understanding myself, and when I'm feeling optimal in my production, and when my wellness is going down, tracking that is important for me. When I start feeling more irritable, I'm not concentrating, knowing it's time to take a break, and agreeing that I need to take this break. It doesn't all have to be me there. And so when it's time for me to take a break, I need to take a break and take care of myself so that I can come back a better, stronger person. The other one that has worked for me is diversity. Not just working in one area, patient care, trying to include, I'm here today. This is a break from my day-to-day, because my day-to-day is patient work out there in the community. So other activities that enrich my career, not just doing one thing all the time. Trainings, doing other things, continuous learning, and mentorship is another thing. I have identified mentors around me, because I always believe human work, you can never know enough. The dynamics, the things are different. So I have people who work with me professionally and also personally, so that they hold me, they guide me, they advise me, they hold me. So mentorship has been a big thing for me, because it keeps me going and it keeps me grounded. And just for me, it's client satisfaction. When I work with a client from point of suicidality to, I'm thinking of starting a business, I want to get married, the sheer joy of that transformation, the resilience that a human being has keeps me showing up every day, that I want to see that again. I want to see that strength in human beings. Thank you.
I think in that regard, Carlo, care work is laborious, right? It's bone-tiring work. And I think if you're working within your community, with your community, for your community, it can be exhausting, right? But I think at the core of what our panelists have shared is the social justice agenda, and that's what's our work is rooted in. And I want to just applaud the work that you do. It sounds relevant, it sounds culturally responsive. So thank you for sharing some insights with us. And for us in the room who work with the diaspora, the one thing that comes to mind, tying in with what we heard from our keynote speaker this morning, it's also about remembering Africa, remembering our people. And I think it's such important work. Please, please don't tire. And I hope there are opportunities to collaborate within this room, in these spaces. And yeah, thank you very much to our incredible panelists. Thank you.
I think I will go ahead and close us out. Bonga, do you have anything in particular you wanted to say? No. Thank you for the panelists. It's been a tremendous day. Thanks for hanging in with us throughout this whole day. There was a couple things, though, that sort of came to mind for me as we sort of close out, and we'll probably recap in the morning again. But consistently, from keynote to the end, we heard about context, curiosity, communication, through everything, even when people were talking about sort of, the basic science and the research, but everything through community-based, work that people are doing, that you still, at the end of it, there has to be connection, community, context. People really have to identify with you in some way, right? And that someone has to be able to connect. And let's not forget the human connection and whatever work we're doing, and being curious about the person in front of us. And so that came through over and over again. And the last point I wanted to just say, because I remember this quote from years ago, in the US at least, and probably we're going through it now again in the US, of thinking a lot about how communities are being impacted every day, and a lot of them, because of socio-cultural, political forces, is everyone we see, because we're all human, and people are being affected every day. we are also doing this work, and so if we're not advocates, then we're participating in the silence. If we're not doing something, going to our policymakers, people in our local communities that you know, it doesn't have to be the president, right? But it could be the local community person that you know leads and maybe doing things right or wrong. And so that came across, I think, through as well, that there are a lot of political factors that are influencing and affecting the people we see day in and day out. And we're a part of these professions that could really make an impact. So alongside all of our clinical work and our research work, if we're not advocating alongside, then we're essentially participating in some of what's happening to people. So I know that sounds maybe a little bit heavy, but I think we can all be an advocate in any of the work that we're doing, no matter where we're coming from, how big or small you may think you are in the field. I think we all can have an impact. And then last but not least, I just wanted to give a shout out to all of our oral presenters in particular and our emerging researchers and the younger people that presented today that are just finishing some of their clinical work or in the middle of a postdoc and coming up here and presenting maybe for the first time at a conference. It was amazing to see. And this is how you do it, and this is how you get better at it every time. And so just a round of applause for y'all for presenting today. Couple of things I want to end with as well, just for sort of housekeeping, that tomorrow we're going to start with the movement again. So if we can try to arrive 8:30 for movement so that we don't cut into all the great things that we have going on and people that are coming to speak tomorrow. 8:30, that movement starts again. She was a great facilitator, so I hope you can come for that. We're going to stay in this room for a group picture now. After the big group picture, I just want to make sure that people don't start running away. The advocacy group wants to take a picture too. And then the mentees from the research program. So please stay in the room even after the big group picture is done so that we can get those pictures completed today. And then the shuttle leaves for dinner at 5:30 on the dot. Meet in the lobby, and we'll all go to dinner for more community building, networking, talking to each other, and having a fun time after this long day of listening and thinking about what we're going to do next to advocate for people with mental health needs. Thank you all.